2023. I'd ask Danielle Cross to do roll call for our presence of SABC members.
Director Maxwell.
Present.
Secretary Gordon.
Present.
Lieutenant Governor Gay. Present. Director Taylor.
Present.
Commissioner Navarro.
Here.
Secretary Young.
Here.
Deputy State Court Administrator Ashley Tucker.
Present.
Jeff Tajner.
Here.
Paul Baumbach.
Here.
Karen Peterson.
Here.
Bill Oberly.
Here.
Controller General Ruth Ann Miller.
Here.
Moving on to the approval of the November 25th, 2025 SCDC meeting minutes. Hopefully everybody had a chance to review those in advance.
Approve.
I have a motion. Do I have a second? Second. Any discussion on the meeting minutes? Hearing none. All those in favor say aye.
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 Opposed? Anyone that would like to abstain? Then it's approved. All right, I will turn it over to Director Hardis to give us the director's report.
Thank you, Director Maxwell. Just a few very brief updates today. The first regarding the health data warehouse procurement. The proposal review committee convened on December 8th and the 10th to begin review of the health data warehouse proposals, as well as conduct vendor interviews. The next health data warehouse PRC meeting is scheduled for Wednesday, January 7th to continue review of proposals and evaluation of best and final offers. The final update is regarding the vision benefits procurement. The Vision Proposal Review Committee met for the final time on December 11th to review scorecard results and develop the recommendation for the SABC. The final recommendation will be reviewed by the PRC throughout this week and will be presented to the committee at the January 26th SABC meeting for vote. Any questions on those updates? All right, thank you.
I believe we have Michelle here to review the medical third-party administrator benefit request for proposal.
Thanks, Director Maxwell. Good afternoon, everyone. Michelle Gass from WTW. I'm here today to present the medical TPA request for proposal. During the November discussion, the SCBC was presented a lot of the materials that are already in this presentation. So my goal today isn't to repeat materials that have already been covered. I'm going to focus on the information that was new in the presentation today. So starting with the contents, we have the context for today's discussion, which I will go over in detail. The background considerations discussed for the next TPA RFP scope of services, both of those were covered in the prior meeting, so I won't go into those in too much detail and we'll skim past those. I will highlight the SCBC follow-ups that were covered during the November meeting, as well as answers that we have for you today or items that we will be working on in the coming months with the SBO on this RFP. The last bullet there, or the second to last bullet, is the medical TPA RFP objectives. They were reviewed during the last discussion, so we won't go into too much detail on those as well. And then next steps with the SCBC today. So focusing specifically on the context for today's discussion, the SBO and WTW have been working together to draft the scope of services for the medical TPA for the upcoming RFP. During the November meeting, that scope of services had been provided in advance to the SCBC for review. There were questions and comments for updates to the scope of services, which we will go through in detail today. The feedback that was requested to be updated in the scope of services has been made. And then again, the questions that were asked, we have reviewed and will provide updates during today's discussion. In preparation for today's discussion, the SCBC was also provided the updated scope of services, which was a minor update that you would have all seen in advance of today's meeting. And then the goal of today is to ensure that the SCBC has the answers to those questions or actions that will be taking place over the coming months to be incorporated into that medical TPA RFP draft. So again, skimming past the next couple of slides because there are no updates to those. We're just we just have the context here that was available to the SCBC in advance of the meeting. So that was the background as well as the considerations that have been discussed to date, whether that was with the SCBC, the SBO, or feedback that has been received over the past couple months. So the SCBC follow-ups for the November SCBC meeting. So what changes have taken place in the marketplace since the last medical TPA RFP? So not much at this point has changed specifically in the marketplace, and we wanted to make sure that was clear for the SCBC, meaning this is one of the most consolidated markets in the country from a provider side. So it does make it very challenging and limits choice and the ability for carriers or TPAs to negotiate on price. So that has not changed, and we're happy to work with the SCBC as you have questions, and we can talk through the RFP draft on that. That's a main one I wanted to make sure to point out today. Another one to focus on is that Delaware has been experiencing the same cost pressures as all other states as well from a nation standpoint when it comes to rising costs, and the employers have been trying quite a bit to make their plan designs updated, more so to give opportunities for the specific the high cost trends that have been going on nationwide. So specifically the challenges come from GLP-1s and of course, understanding the rising costs that have pushed employees to innovate benefit designs and alternative insurance models. So we at WTW want to work together with the SBO and with the SCBC to think about ways to enhance plan designs and put that in front of the SCBC and consider your feedback and how you as a group feel that those updates would help the state. But again, those will come in discussions throughout the next couple months, and as we prepare an updated RFP with the questionnaire to address those challenges that have been taking place nationwide. The next slide is more, I would say, straightforward, and what I mean by that is the first item specifically highlighted here is what was updated in the scope of services. So the scope of services document, there was an item that was asked to be updated to include and specifically call out retirees. So what I listed here was what page number that was and what was updated in the scope of services. And again, that was provided in advance of this meeting to the SCBC. As I mentioned on the prior slide, one of the main things we want to work with the SCBC on is understanding what type of plan design changes and member cost shift, primarily around steering members to lower cost facilities, can be done with this RFP. So what we plan to do on the Willis Towers Watson side is work with the SBO to model revised plan designs for the SCBC's consideration to look at how to address those steerage concerns.
Yep, Bill Overly. Could you clarify for me what you're talking about in terms of plan design changes?
So currently, I think it's been stated quite a bit, the designs within the state right now make it challenging for an employee to think I should go somewhere else because it would save cost to my employer, because for them it's more convenient to maybe at an appointment do their labs specifically there, right? So if there is nothing driving or no incentives driving employees to make smarter decisions that could save money for the state, they may not do that. So we want to talk through over the coming months with the SCBC where there are options to allow you to do that.
Okay, well, I appreciate that. I've been a big supporter of revisiting the whole steerage issue, and that's really what we're talking about.
Yeah, and I think with the current plan designs, it's very challenging to steer members, and that's why we want to look at opportunities with the state.
Just going back to the cost drivers, I think we need to be honest with the reality in Delaware and understand that we've also mandated a lot of coverage requirements, and so I think a lot of those are really helping Delawareans, but it also has an impact on how we negotiate here. So we can just include that in the spectrum of what's driving costs. I think that's a more honest assessment.
Yeah. Another item that was raised was around direct contracting with medical providers and healthcare systems. So at this point in time, we are proposing an addition to the questionnaire, similar to what we did with PBM, to have vendors confirm their ability to support the state in this case, but understanding that direct contracting would require substantial state funding and staffing and the support to the development of that nationwide. So we do need to be realistic, but at the same time, highlight to vendors and ask for their support as a part of this RFP in the questionnaire. So we understand the challenge and we understand the need, but we also want to make sure that we're being realistic with the SCBC, that the reality of being able to do that fully is very challenging. So we would need to keep that in the back of our minds as we're going through this RFP process.
Jeff Tashner.
Thank you. Michelle, on that point, just a couple questions. I know you talk here about substantial additional costs, but there would be current costs that would be saved if we went to direct contracting that could be used to offset some of those costs, right? And part of what I understand, I mean, I found it interesting that we're doing it here because my understanding is the group of people we're talking about, the medical EPAs, this is kind of, if they help us go to direct contracting, they're almost working themselves out of a job. Right? I mean, and in my world, organizers understand when they take on a job that if they're successful, they're working themselves out of the job because that's what they're supposed to do. But I don't see this industry as one that has any interest in working itself out of a job. So I'm a little dubious about our ability to crack through here with the audience that's going to be responding to the RFP. But I know outside the SCBC, I've had both legislators and providers mutter the words direct contracting. So I think it's an area we need to look at, but I'm not convinced that we're going to accomplish anything in our medical TPA RFP because they'd be working themselves out of a job. But I encourage Highmark and Aetna to contact me. My name is Jeff Tachner. My number is 302-382-3518 and convince me otherwise. Can I go back to your first bullet?
Sure.
And they have until after the holidays to.
They can do, I am available from now to the day I retire, but
Just
for them,
checking.
that could be any day from tomorrow to the end of time. So they just gotta pick their choice. This whole thing about the consolidated market, it's been the bane of my existence for my 15 years on the SCBC. I guess my question is, what can we do about that? I mean, in all seriousness, and I've been waiting for somebody at some time to tell me, Jeff, we're not going to do anything about it. We're stuck, at which point I'll turn my attention elsewhere. But I think this is a really big problem we have in Delaware. And if there are things, and they may be beyond the SCBC's purview as a state that we can do, I think this is another area we really need to pay attention to. So just wanted to
Can I jump in?
vent my screen on that.
I don't want to put, or can I jump in?
Yeah, sure.
I don't want to put our insurance commissioner on the spot, but I do want to note that over the course of his time, I think he's worked to get additional providers here in the state of Delaware. And I know that it's hard, but I also know that it's like a continuous process. So I would lift up that some of that work is being done, but how we can help it is maybe the question.
Right. How we can maybe move it along a little quicker than it's been. Yeah.
Secretary Link Young.
Sure. On this point, I just want to add that at DHSS, we are doing a lot of work to explore with CMS, something called the AHEAD model, which would be a multi-payer opportunity to align on driving lower costs and more competition in our healthcare market, and sort of moving more dollars into population-based outcomes. So it is not the same as the work Commissioner Navarro is doing to bring new providers in, but it is certainly aligned in trying to drive lower cost market-wide.
Insurance Commissioner, you raised your hand.
Yeah, sorry, I'm having camera issues. So I think Jeff is right in that direct contracting would not necessarily need a TPA, but I would have to see or hear that it's been successful in other state governments. I mean, I don't know if other state governments are doing it, but that would be something that maybe Willis could tell us.
Yeah, and I'm happy to take that as a takeaway. To understand. What was that?
Oh, I do have a response.
Okay.
I think not just other state governments, but similar plans that self-administer, right?
Yeah.
And what it takes in terms of the resources.
Yeah, and this is Director Hard's Statewide Benefits Office. So we did look into that. A few states have tried it unsuccessfully, unfortunately. So North Carolina being one of the most recent ones in 2019. I'm happy to send the information on this, but they launched something called the Clear Pricing Project, in which they tried to self-administer again and direct contract. Unfortunately, all the hospitals in the state refused to contract with the state, which would have resulted in them being out of network. So the state ended up conceding in the end. They did have some direct contracts with independent providers, and those actually all end December 31st of 2025. So they all end this year. Happy to see if we can reach out to our contacts over there to see any potential outcomes for that. But to my understanding, that pilot has now ceased because of the non-supportive hospitals in that situation. California also explored it. However, from the TPA side, what you really still need is someone to adjudicate the claims, right? And to your point, TPAs aren't going to adjudicate claims for a network that they don't manage, at least not with significant fees associated with that. So they dabbled in it, but never ended up executing any contracts just because of the barriers they face with the TPAs. But happy to share that with the full committee. To my knowledge, there are no states who have successfully administered large direct contracts. Now, I think the point for this RFP is to add some language in the contracts to allow for one-off pilots, right? I know there's a few providers, to your point, who have actually come to us as well who wanted to do some type of direct contracting, but the limitations are the language we have in our contracts with Highmark and Aetna. So what we would like to see in the contract, which is a direct reflection of the RFP, is an allowance for the committee, for the state, to go out to independent providers for pilot opportunities while not fully committed or not fully looking into larger contracts at this time, but to really start the process.
Thanks, Stephanie.
Absolutely.
Stephanie, Director Maxwell are here. Didn't you, I think we've had a conversation, but I think sometimes we get lost in that if the state of Delaware group health insurance plan, right?
Yeah.
But there could be retirees all across the country, right? And so utilizing that network and being able to have coverage for people that live outside of Delaware would present challenges or concerns for you as well, right?
Absolutely, yes. That's why it would need to be done in tandem with a TPA network that exists already, which is where we would run into the problems with it.
I'm not questioning what Brian said, but just to understand it, does that apply equally to Medicare retirees and pre-Medicare retirees? Is that just more of the pre-Medicare retiree population?
So it's more the pre-Medicare retiree population, I would say. Medicare, we do, of course, under the supplemental plan, of course, cover for out of state. But my understanding is if we were to explore any type of direct contracting, it would not be for the Medicare plan. It would be at least starting with the commercial.
And I just wanted to separate that because I know when we talk about retirees, it's a big group. But I think the bigger portion of the group are the Medicare retirees who wouldn't be in that situation.
Yeah.
But you're right, there's a group of probably several thousand pre-Medicare retirees that we'd have to address that concern.
Teachers, right? Teachers, let's talk being teachers, right?
I think there's a couple troopers in there, a couple teachers, a couple other people.
Definitely not elected officials, right?
No.
Quick comment, not offline of this topic. Should we be identifying who we are before we start speaking?
Yes,
Yes.
just because of the new.
Yeah, I was seeing this stuff move in behind me. I'm like, oh, yeah. So,
Yeah, we're trying to.
this is Paul Baum back who asked that question.
Okay, and then just trying to keep us on track here, this last item was more so just around the definition, which has been provided in advance to the SCBC, but I'm happy to speak to that in more detail if anyone has questions.
Director Maxwell here.
Yeah.
Just a follow-up. As far as if this direct contracting, I'm just taking it a step further, like, we don't actually have a system here
in the state, right? Would we have to go procure a system to be able to handle our claims? If we were to.
Yeah. As a part of that process, yes, for defining the direct contracting with the.
Gotcha, and we would be responsible for throwing out like statement of benefits and the like.
That's why we were trying to highlight with the SBO here specifically around the amount of like work and funding that it would take to put those financing.
Bill Overly.
Yeah, and if I might add, I've been a big proponent of direct contracting, fully realizing it, the magnitude of the problem administering it is pretty significant. But with that, you get complete transparency. You actually know what you're paying for and how much you're paying for, which has been the main attraction to me. Jeff and I, and I'm not gonna, I won't use names. Jeff and I were in a meeting with a hospital provider who offered a direct contract with the state. Now there were strings attached, and clearly it was, I don't think it was an honest offer, but there have been providers out there who I think are interested in looking in that direction. So I realize it's a long-term initiative. I mean, basically you have to hire administrators, many of whom might come from former TPAs, and bring them in-house to administer the program. But I don't think it's out of the realm of pursuing, I'll put it that way. So.
If I may, Director Hardis, I also just want to note, there's also a clinical component to that, right? We also have to be in compliance with all Title 18 insurance requirements.
Yep.
So for prior authorizations, you need to have clinical staff, physicians who are able to review prior auths or any clinical approvals. So there's that component as well, perhaps that again could be outsourced in another contract. But I just wanted to note that as well. And also, I do just want to say as part of, we have a facts and figures website on the SBO website that does have our incurred claims reports where you can see pricing per procedure, per drug. All of that is public, and it's not under the Department of Human Resources, but I always like to promote the DHSS resource. The Cost Aware tool does have pricing for procedures and certain services by healthcare system, by provider type, as well as by TPA. So that's also an opportunity as well. And I believe they've always been interested in incorporating more the health plan data from the state, which we're happy to work with the DHSS as well the DIN to do that as well.
Jeff Tashner. Do I have to say my name then, since you said it? Jeff Tashner here. So I have a disclaimer, and then I have a question. First of all, a disclaimer, I didn't want you to worry. The meeting Billy talked about was not in our SCBC capacity, but it was as union representatives, working with the legislator, talking with providers around a piece of legislation. So it wasn't like we were out cutting our own deals. Administrative fees. I think I know what we pay annually to the TPA, but can somebody tell me what that number is? What we pay our TPA on an annual basis? I think I have a ballpark, but I want to hear it from somebody who actually knows that number.
I don't have that number offhand. I don't know if Brian that's online could answer, but if not, we can take that away from the WCW side.
The point I ask is I think it is fairly significant.
Yeah.
And I think it is significant enough that if that cost were no longer incurred by the state would have the ability and have the funding to bring in some of these things we would need to administer. And what I would hope we would do is not just say, there's a lot of roadblocks to direct contracting, but actually look at what we could do with that money we would save in terms of what we would need to self-administer, especially because you made me smile when you said the reason North Carolina failed wasn't because they couldn't do it, but because the hospitals wouldn't let them. And I think if that's an issue we face here, then we got to figure out how we have conversations with them. But I would just be really interested in actually doing some sort of an analysis of our size plan. What do we need in terms of people to review claims, a medical expert, that sort of stuff? What would be the anticipated cost? How does it stack up compared to what we currently pay? It costs more. Would we actually save money, Mr. Budget Director, which I think would be a good thing? And then as Billy said, unlike our current situation, we would have direct access to the data we need and wouldn't run into these roadblocks of, well, we can't tell you how we're spending your money because that's a deal between us and the provider. So I really think it's something that we should spend some time and energy looking into.
Mr. Bombach.
Yeah, just briefly to tack on to Mr. Tashner. I think that there's understandable hurdles if we were to in parallel have direct contracting. But I think what Mr. Tashner is pointing out is looking at a wholesale swap at some point in the future is well worth exploration. That avoids those hurdles of having parallel costs as opposed to doing it all. I'm getting eyebrow curls from the.
No, I was just thinking with my budget hat on, there are other areas in state government where we have to procure medical services and we go through a provider and the provider's doing negotiations with the hospitals. And we're trying to figure out how we can get to the hospitals to cut us a better deal. And so that's probably a little bit smaller scale than what we're talking about here, but obviously it just has my wheels turning as to how we could see how that would work. And it's not so much us administering the claims, it's a matter of the negotiation process. And so that's kind of part of it as well. It's like if we could be at the negotiating table as opposed to going through the TPA and being a part of that. But sometimes that requires legislation to actually effectuate some of that change. So that's why you saw my facial expression.
That's right. I like wheels moving.
Commissioner Navarro?
Thank you. Trinidad Navarro here. So just a quick question. I don't mean to step on anyone's toes or be outside of my lane. And I guess for you, directors, I have contact with folks who are no longer employed at one of the largest health insurers in the state of Delaware, who could potentially, I'm just thinking out loud, but potentially be a consultant who could maybe walk us through the requirements, or at least what they require as far as different experts, the physicians on call, the prior auth, and all the other stuff that was already mentioned. How would I go about doing that in a way that doesn't necessarily violate our own rules, and maybe work in collaboration with the SBO to maybe do that?
Thank you. Dr. Hardis, State Wide Benefits Office. You can feel free to email me directly any contact information that you think would be worth exploring. I think we would also have to look within the terms of our contract with WTW. We do have certain consulting services carved out specifically in our current agreement. But of course, that doesn't mean we can't explore other opportunities that are more specialized to look at this. But I believe WTW has previously, I want to say it was probably 5 or 6 years ago, completed modeling for what it would cost to self-administer the GHIP. This is not, of course, the first time that this has come up. So, but feel free to send me any contact information. I'm happy to discuss with you. And I think we can also still work within the bounds of our contract with Willis Towers Watson, who do have the actual claims data for our plan specifically to better model. So I think a barrier with using an additional consultant or outside resource is that they either wouldn't have our exact claims information, or then we would have to enter into an agreement in order to share those claims information, but definitely not something that would be impossible. So feel free to reach out to me directly, Insurance Commissioner.
Yeah, I'm not suggesting that this person would even be interested in consulting, and that's why I asked it. I didn't want to step on any toes or violate any of our rules. Just have that conversation, which I intend to have in the next couple of days, among other things. But I'm just curious. What WTW did a few years ago with the estimates for costs. Do we know that? Can they share that? Have they shared that?
Sorry, this is Stephanie again. I can go back and look at it. I'm not sure if we were able to quantify. I think substantial was it was mostly the term used, but we're happy to go back and look at previous meeting materials, which I'm sure would very much need revised. We've seen a lot of course, increases in costs over the last 5 or 6 years, but we're happy to go back and look for those.
Sure. I mean, I just think it's worth researching and not just talking about, right? But I don't, again, I don't want to get out of my lane.
Absolutely. And I will say, I do also have a response to Jeff Tashner's question related to the administrative fees. So in fiscal year 25, we paid $34.5 million in TPA administrative fees. So about 6.7 for that was with Aetna and 27.8 million was with Highmark. That includes Medicare and non-Medicare. So about $35 million a year.
Thank you, Jeff Tasher. I thought it was somewhere between 30 and 40 million, which again is fairly significant when you think about what that would allow you to do to stand up your own.
All right, so that takes us through the SCBC follow-ups from the November SCBC meeting. Again, we had gone through the medical TPA RFP objectives during the last discussion. There were no updates to these slides. They were just here for reference for the SCBC and the next slide as well, which was the continued RFP objectives. Now, the next steps following this discussion today is that Willis Towers Watson will work together with the SBO to continue to incorporate feedback from the SCBC as we prepare the medical TPA RFP draft. We will work and develop that over the coming months and review in March 23rd of 2026. So after the new year, we will have a discussion with the SCBC to review that full RFP in detail, which again, you will be provided in advance of that discussion. And the SBO and WTW will work to incorporate any feedback following that review. And then there will be a vote to approve that RFP April 20th of 2026.
Bill Overley? Yeah, Bill Overley. Going back to page 9, as relates to APMs. At some point, we're going to have Christine Vogel here to discuss APMs. There are a number of iterations of APMs, and I'd like to better understand what those iterations are and what in fact we ask for in the RFP.
This is Director Hardis. So I will say we did speak with Christine. She has requested to present at the February 23rd SCBC meeting. So we are planning to allocate time for her to discuss alternate payment models. And I'm also happy to follow up as we're developing this RFP on what exact language has been included previously related to alternative payment models. We do have a few performance guarantees in place specific to those. They mostly do align pretty much identically with the Department of Insurance and the Office of Value-Based Healthcare. I'm happy to share that with you, yes, but she will be presenting at the February SCBC meeting.
Paul, you have something else?
Jeff and I were just kicking around prior to the meeting that we may need some time with Christine to better understand the APM models and what in fact we're trying to define in the RFP. And one of the ideas that came up was perhaps another publicly noticed workshop for the SCBC because we're always short on time. But I don't think this is one that we can not focus on or have our full attention on before we go to RFP. So I just raised that as an issue.
Hold on that.
Yeah, thank you. So on slide 9, the first thing on the left, increased proportion of spend through APMs. That differs from the wording in this draft scope of services saying offer solutions that increase GHIP spend through APMs. That proportion is really important because on this, there's an inherent and reduction of GHIP spend through traditional models that's missing. But as long as you use the proportion, I'd like to see the wording here align with the wording here. Does that make sense? Thank you.
Just Director Maxwell, just a friendly reminder to committee members, we are going to have Christine Vogel be present at our February meeting. Obviously, I want to utilize that time best as possible. So if we can get an agreed upon agenda, because Mr. Overley just mentioned about alternative payment models and the iteration. So if that's definitely an agenda item we want to have included, just to make sure we give that feedback to Director Hall just in advance of that meeting. Commissioner Navarro.
So essentially, that's what I was going to say. She'll be there in February. I would respectfully request a half an hour. I know we are short on time at every single meeting, but this is not something that you can just talk about for a few moments and not have the feedback. So 30 minutes is my request. And to Mr. Oberle's couple of his comments, she's on the line right now, and I don't know if we have time or if you have specific questions that we can at least take and maybe get you answers later. But again, I just like to request 30 minutes for February.
If I,
Bill Oberly.
if I might respond, I would be glad to forward, I think that we're in a bit of a time crunch here today, but I'd be glad to forward to Director Hardesty any questions, specific questions I have for Christine, so she's prepared. I certainly don't want her to walk in here and be blindsided. That's certainly not my intent. So I'd be more than willing to do that. And I think others around this table may have.
Yeah, she's listening in right now, so she won't be blindsided.
Well, I mean, I could go into it now. I've been reading HCP land report, and it expresses a range of what one could categorize as APMs, and that's really what I want to explore with Christine in greater detail. I'm not sure this is the time or the forum to do so, but when we use the term APM, it could apply to a range of different models, and that's what I need to better understand. What are we talking about when we use the term APM?
So I agree, now's not the time, but she will have materials prepared in advance. And perhaps that will generate some questions from that we can get to the SEBC well before the actual meeting.
Okay, thank you.
So did you have anything else? Is that
No, that covers everything for the CPA.
great? All right, moving on to the GHIP strategic framework.
So we have Hope Mannion on the line to do that presentation.
Hi, can you hear me okay?
Yep.
All right, thank you. Michelle, do you mind scrolling ahead to the contents? Yep, so similar to the prior presentation, there are not a lot of changes on this deck from the one that was presented last month. So we're gonna go through things pretty quickly and just try to facilitate a little bit of conversation before we get to our next step. So we will review the framework, which exists on slides 6 through 12. And then the next step is really voting on the framework. So with that, Michelle, if you don't mind skipping ahead to slide 6, and we can talk about the first goal, which is to improve the health of the GHIP members. And then within this goal, we have 4 strategies and a list of tactics and considerations. So I'll pause a moment to see if there was any reaction questions that we could address on this goal.
Hold on back.
And I had some minor stuff that I emailed late. It was, I'm gonna say cosmetic on the first few slides. I don't think I need to go through them in the meeting here. But on this, on the first slide 6, strategy 2, the first bullet, explore conducting HRA surveys, is because it wasn't identified in any special color. I'm assuming, was that present 2 or 3 years ago with the previous framework? And if so, was it explored or not?
I can respond to this. Thank you, Director Hardis. This was not a part of the previous framework.
Okay.
Health risk assessment surveys are still currently conducted through Highmark and Aetna through the TPAs. We have promoted those. They do contain a level of PHI that our office does not utilize, and we try to follow the minimum necessary rules. So if we don't need to have that member's information specific to any type of behavioral or medical conditions, we don't obtain it if we're not going to utilize it. But we have not internally conducted any health risk assessments, and it has not been part of the framework previously.
Okay, all right, and I imagine that therefore there's no convention in what's presented here to show stuff that was existing in the current framework and that which is new to this proposed future framework. Is that correct?
That is correct. The previous framework, I think, was presented at the September and October SCBC meetings. There are some components that carried over, but the majority of what's in the framework is new, just based on feedback from the committee and what we've seen over the past few years.
Thank you.
Any other? Okay. We're ready. We can move on to the next goal, which is on slide 8. If you don't mind advancing, please. Thank you. So goal 2 is to ensure members receive high quality and safe care that is cost effective and improves outcomes. We only have 2 strategies here, as well as our list of tactics and considerations. So I'll pause to see if any members have any questions on this goal and associated tactics and strategies.
Yeah, sorry, Paul. Yeah, Paul's on that.
No problem. On the upper right in the considerations, I really don't like the word consumeristic. It feels very, I don't know. I think consumer is quite sufficient there. We're talking about consumer behavior, right? So I'd suggest that's a superior word. Under the tactics, and I don't know if this belongs someplace else, but I think price transparency would be useful somewhere in here. I don't think that I saw it in any other of the goals. So wherever it is deemed the appropriate home, I'd like to see it both as a tactic along with consideration and measures.
The term consumeristic in this context is alluding to strategies within health benefit management broadly, where we are encouraging consumers to do things like evaluate providers and do price comparisons and quality comparisons, and then make decisions that result in, you know, the best use of their healthcare dollar or your healthcare dollar in terms of outcomes, you know, similar to how consumers shop for other things like cars or goods. So that's why we're using it that way. So, you know, I don't know if, you know, it's easy enough to just say we could change that, or do we track changes to this language and, you know, let other committee folks weigh in on that change and then include it in the vote at the end. So I'll just kind of defer to Director Hardis on, you know, can we collect some edits like this as we go, or should we be taking these away?
Lieutenant Governor.
Well, I don't know. It sounds like she was using an industry specific word rather than talking about consumer behavior, like she's using it to reference.
Yeah.
Something. Like, did that change your?
Well, I think if it's going to be used throughout in that, because it's used in more than once in here, I'm fairly certain, then perhaps on the first reference of it, there can be some in parentheses, meaning having to do with behavioral finance kind of decision making, or something that explains that use, because it's not a layman term. And it just, it feels a little bit unnatural and highfalutin unnecessarily. And if there is indeed industry reasons for it, then I think it would be helpful to have that in there to make this a more readable document.
I'd agree with that.
So like add a footnote and explain what it means.
Sure.
Yeah.
Okay. I think we're ready to move on to the third goal, which is on slide 9, around managing healthcare costs for GHIP and GHIP members. We have 6 strategies under this goal on the next few slides, and associated tactics and considerations. So any discussion here on managing healthcare costs for members?
I hope. Jeff Tashner here. I think I mentioned this at the last meeting, but I struggle in this area, and it's a step back from the goals. It actually goes to our mission statement and the definition we have for affordable cost, which, as I read it, is saying we just want to stay consistent with the current trend. And my time on this committee, there's been several instances where we have evidence that in Delaware, our cost, the price, is higher than in surrounding and comparable markets. And I was hoping in the strategies. So first of all, I think we need to change the definition of affordable cost, because this basically says if we're paying 25% more, we're going to be comfortable if we just keep paying 25% more than we should. And I don't think that that's acceptable. I think we should try to get in line with comparable and surrounding markets. And I was hoping in the strategies that I would see something, and I think the closest that comes to it, quite frankly, may be strategy 4. And to me, it's a little bit, I just feel like it's a little bit short. So I don't know if there's anything that can be done. You pay a cost because somebody else sets a price. And the problem we have in Delaware is a price problem. And it's that what we are charged is significantly higher than comparable and surrounding markets. There's been a number of studies that have shown that. It was the basis for our attempts around HB 350. And I just, personally, my feeling is this falls short of getting at that for the GHIP. So I struggle.
I think this framework is intended to be, a set of guidelines and goals and strategies for SBO to use to manage day-to-day the employee benefits program offered by the state, and is not intended to speak to broader strategies, which likely include collaboration with other entities within the state government as well as legislature to influence the healthcare market more generally within the state of Delaware.
And I appreciate that. I can just tell you, me as an individual member, I will not be voting for this framework because I feel it falls short on addressing the price issue, which is a problem for the GHIP. And unless we do something in our goals and objectives to address that, I can't in good conscience for the members I've been appointed to be here to represent say that this is an acceptable strategy to me, because quite frankly, it looks like we're continuing a practice of how can we shift cost on the plan members rather than how can we reduce the overall cost for the plan by driving down the prices. So that's where I am in terms of this part of it. And for me, it's a deal breaker on my ability to say that I support the overall strategy.
That was a lot, but I will say, this is, we're only one part of the equation, and I know everybody has access to the 62 people that, gather during 6 months of the year. That's who really needs to kind of help us solve this problem. So, I mean, if you think there's something we can do around this table to lower healthcare costs by what's priced in Delaware, I'm all for it, but I don't think you get there without legislation. And we've taken a swing at it, and it didn't really stick, right? We're having to unwind a little bit with regards to that. We're going to get some transparency around it, hopefully, right? But as far as lowering that price, when you're saying based on those studies, I don't see how that's going to be different.
And I appreciate Jeff Tashner again, and I appreciate that, Brian. The challenge I have is, again, having sat at this table for a number of years.
So then let's develop an agenda, a legislative agenda, because it seems to go one way, not the other way.
And that's what I'm asking is like, what can this group do to advance to another group and say, like, first of all, are we willing as a group to say pricing is a problem in Delaware? Because that's not something I think we've done. And all we've done over the years, and I'm not going to blame anybody, is we've talked about how we're trying to do that. Everything we do where we talk about cost savings, quite frankly, is, I think the technical term, BS, because it's been cost shifting onto the plan members or attempts to cost shift. And that's what is a problem for me. Let's get honest and say, like, look, problem is prices. We have a problem. What can we do? And if we can't do anything and we got to kick it to the General Assembly, let's do that. But we've never even been as a group willing to do that. I'm just saying that this document falls a little bit short for Jeff Tashner because, again, it fails to call out what we all know is one of the significant problems. And while we talk about cost savings, if you look at any of those things that we're talking about savings, it's going to save, it may save costs for the state, but let's be honest, it's going to be doing that by putting more cost on the plan participant. So if we're going to do it, let's be honest about it. And I won't be voting for that stuff. But in the past, it's always been packaged as this is gonna save. It's not gonna save. We're just gonna shift costs from the state onto the plan participant. And that's been my biggest problem.
What about that?
Thank you. Actually, I want to go off of Mr. Tashner's stuff. The measures here, and goal 3, strategy 1, the measures talk about year-over-year trends. And I think one thing that would perhaps address a small piece of Mr. Tashner's concerns is a lot of times the trend is the percent year-on-year trend, okay, as opposed to the dollar level and the dollar level compared to the region. And perhaps if we flesh out, increase the size of these measures and be explicit about that, that is something that Mr. Tashner would find a positive development is in that. Secondly, on the same page, but in the next strategy, the last bullet is make recommendations to General Assembly about legislative strategies. I don't think the SCDC has done that. And I'd say it might be a good idea annually, maybe late fall before the session resumes or a session starts, to share with the legislature what changes we would like, the SCDC would like to see the legislature consider, and have a tradition of annually maybe 2 months beforehand, spitball about the general ideas, and then 2 months later, maybe after, if there's an election, in November election, to say, given the incoming General Assembly and administration, what are reasonable requests of areas that it's appropriate for us to ask? And I think they'd be received well when it's the body of the SCDC shares those. So I threw that out as being constructive ideas.
Yep, I don't disagree. I think my comments reflect that we should be more proactive in engaging as opposed to reactive to what's coming towards us. So I would definitely support that, and we should get that as part of our framework as to when we can get it on, be delivering that to the legislature.
Absolutely. This is Dr. Hardis. So I was taking notes as you were talking. So I believe we could add a new tactic in goal 3, strategy 1, that specifically states develop annual recommendations to the General Assembly on legislative strategies to reduce health and pharmacy spend under the group health insurance plan. Or we can keep it broad and not even say under the group health insurance plan to make it more broad state impacts. And to Mr. Bomback's point, as far as what those measures and what that outcome would look like, we could put a specific date on it, or say by the fall of each year, have a list of considerations to share with the General Assembly for the upcoming session, just to get some very specific timelines in place and to make that a recurring annual recommendation.
If I'm Bill Overly, I apologize, Stephanie, for calling you Hardesty. I went to school with the Stephanie Hardesty.
Oh, great.
So
That was it. I saw downstairs.
Spend, I'd be a little more comfortable with the term pricing as opposed to spend.
Okay.
The spend and pricing are interrelated, but really what we're talking about is the pricing model. When you consider that one of the Delaware Hospital owns a hospital in a contiguous state, and I won't cite a percentage, but it's significantly lower charges for procedures in that contiguous state than it is in our state. I mean, it's a big red flag to me that we're being overcharged for what we're paying.
Thank you. Kyle Gay, I was just wanted to note, and I completely respect everyone's vote is their vote, and we have to just kind of make decisions up and down. But I do want to point out that while there isn't a big bucket of like bring the cost down from where it is today, a lot of these strategies go to some of the things that we have identified as high cost drivers. And that if we, I think the key for me here is that these strategies have to work together and has to be looked at as a holistic approach. And I think if we are able to be successful, especially with our upcoming RFP, in focusing on a lot of these cost drivers, we get closer and closer to our shared goal of actually reducing costs for state employees and benefit plan members And also making sure that we make healthcare, hopefully with our spot in the market, start to drive healthcare trends in the way that many Delawareans need them to go. So I do see some of the cost saving pieces in here. I think that's a reason to support the strategy. I specifically wanted to point out that under goal 3 strategy 2, there's a mention of state Senate Joint Resolution 7. And I believe we could strike that reference, because then the bullet point would say explore PBM and pharmacy cost reduction strategies, which I think is more broad, and that we should very well take what was in SJR 7, but we should very well look outside for other strategies as well, and do everything we can in the space.
Well, real quick, Commissioner Moore, you had your hand up for a while. Did you
I did.
have something?
And yeah, I was trying to get in the queue there, but basically what Bill and Jeff and the Lieutenant Governor said, I concur. I was trying to say that earlier. I think that there's nothing in there that addresses hospital pricing. And I think leaving it up to the employee, we really don't have, there's no reason to change behavior. And so it's, to Jeff's point, it really is cost shifting. So if we could put in there something along the lines that we endeavor to work with the General Assembly on an annual basis to address hospital pricing and high cost claims, something along those lines. I would have said it sooner because I think I repeated what everyone else said.
Thank you. Jeff Asher.
Yeah, Jeff Asher. I want to thank everybody for the conversation, because as we talk, it helps me think of things. And I said I wouldn't be voting for this. And as I'm sitting here thinking, here's something that would make me feel a lot better, that we as a group are trying to do something about the price issue. So in 2023, the Vermont State Employees Health Benefit Plan and the Vermont Health Education Initiative went to their legislator and requested support, and they conducted a reference-based pricing study of their state employee and state educator plan. It was released last December and showed that there was the potential for significant savings within the plan. My understanding, talking to my counterparts, that cost them about $15,000 to $20,000 to do. So if we put in there a tactic that we would conduct a reference-based pricing study of the GHIP, I am pretty sure you would switch Jeff Tashner from a no to a yes, because that would then get us finally a comparison of what we're paying in the GHIP to a reference-based price, and let us know what, if not, is available. The study's available. It's like 24 pages. Like I say, I talked to my counterparts up there. So I would love for us to say we'll commit to do a reference-based price study of the GHIP spending to see what we could save if we were to set it at 200% of Medicare or whatever.
Secretary Link Young.
Sure. Thank you for that. And just to sort of, and nice to meet everybody
Yeah.
in person for the first time, that I could finally get down here. So I think I'm excited about this discussion. I do think it is really important for this body to be clear in saying that hospital prices are a problem in the state. And I think there's a lot of conversation already happening with the General Assembly along those lines. Commissioner, my team, like a lot of people are having a serious conversation about that. I do think it's important that we not fracture that conversation, because, the sort of the providers on the other side of the table would love nothing more than for everyone to be pulling in different directions all across the state. So I do think the most useful thing, from my perspective, that we may be able to do here is just to signal that there is a serious problem and that we are all working together across the state on a set of solutions that will be impactful here. Again, I alluded to this earlier, but I think there's a ton of potential in the work that Christine's going to talk about, and that my team is doing around moving more and more payment into accountable population-based dollars rather than fee-for-service payments. And so I would hate to see us like fracture where people are headed by being too specific about these sorts of things.
Hold on, Matt.
Going on a different direction.
Well,
I'm happy to wait while we keep this in it. That's fine.
Chair this, please. He's directed.
Believe me, I tried.
All right,
I tried.
Bill Overly.
Bill Overly. I'd like to second Jeff's thoughts on this. I mean, I've been at it about 15 years as well, and we seem to be always end up at the same place we start when we begin to try to define the pricing problem that we have in this state. And I think whether it's SCBC initiated or General Assembly initiated study that would demonstrate the disparity between reference-based pricing level, whatever that you can look at 200, 250, 300, and where the pricing exists now in the marketplace is going to be pretty telling. I mean, the outcome will probably be shocking to a lot of people in the general public, and I think that then gives you a point to begin to discuss how do we deal in bringing those prices down more to a level that is reasonable and fair. Now, Jeff and I go back far enough. I think you were on the SCBC. I was on the subcommittee when we had Johns Hopkins come in and presented a study to the SCBC that kind of did a comparative analysis on reference-based pricing and what we were paying. And I remember specifically one of the analysts from Johns Hopkins saying that most of the providers in the state could turn a profit receiving Medicare-only rates. And that was put into the record before the SCBC. So I think moving in that direction, at least articulating it for consideration, would be a giant step forward. And quite honestly, it would give me some sense of relief that we're finally moving in the right direction after all these years.
And so what you mean by reference-based,
Secretary Link Johnson.
sorry, what you mean by reference-based pricing, it sounds like isn't like what California does, where you really mean being serious about our prices, like commercial price caps as a percent of Medicare type
Correct.
concept. That's, yeah.
Correct.
So I worry a little bit about using
Yeah.
the particular terminology if it matters, but I think we should work on it.
It typically means tying the reimbursement level to a percentage of Medicare, whether that be 100, 200,
Sure.
300.
Sure. I mean, I think I'm totally there, and that's a lot of
Okay.
what everyone's, I mean, I think otherwise,
And-
Christine.
Well, hold on. Karen Peterson, do you have something on this?
Yes, thanks, Mr. Chairman. I also want to support what Jeff is proposing. I don't think we can keep going back to the groups that we represent and tell them we're doing what we can to control costs, when in fact, we're not taking any concrete steps in that direction. And I believe that a study, which doesn't sound very expensive, on reference-based pricing would be a good first step. And it could also get me to support this particular item on the agenda. I just don't, if we keep doing what we're doing, we're going to keep getting what we're getting. And unless we go outside our comfort zone and think outside the box a little bit, we're just going to keep, as Jeff said, shifting the costs to the employees and the retirees, which is what happened, of course, when we set the premium rates for this year. We just keep shifting the costs. I don't know why we wouldn't be willing to cough up $15,000 or $20,000 to have such a study done. And at least it would give us the information we need going forward. And this isn't proposing that we tell the hospitals what they can charge. This is proposing to tell the hospitals what we will pay. And that's a whole different thing. And we're a huge group. In 130 some thousand people would be meaningful to the hospitals if they were to lose that business. So I fully support what Jeff and Bill have said about going forward with at least a study. Thank you.
Yeah, and just to clarify, there have been numerous times in the last 8, 10, 15 years that different people, Billy referenced Hopkins, different data points have told us that we've got a problem with our prices relative to a Medicare base. And part of the challenge, quite frankly, we've had is like, how do you get an analysis that really tells you what's going on in Delaware? And there were numerous conversations with legislators years ago about a reference-based price study, and it got to a certain point, and then other powers prevailed, and it went nowhere. So when I finally heard about what Vermont did within the scope of their plan, you talked about what can we do within our plan. That's why I thanked you for your comments, because it triggered that thought. We control this plan. We control what we spend. And I just think it would be an incredibly helpful start for us to say, if we could have that same kind of study done, what does it tell us about our plan? Look, I'm the first one who will admit, if it comes back and says the opposite, I've got to accept those results. Somebody's now done that study. But the problem is we've never even been able to get the study done on our plan so that we have some kind of quantification of what our pricing problem is or is not. So then we can start trying to figure out how do we attack it. And that's why, this conversation triggered it. And again, Brian, I thank you for talking about what we can do, because it brought me back to what Vermont did.
Great, thank you. Paul Von.
One thing that I was digesting this stuff, trying to put things together, perhaps requesting from the legislature and meeting in January, the joint House Senate Health Committees with DHSS, Department of Insurance, Healthcare Quality Office, to explore this issue and see what action would be appropriate. It's not something we can ask for now. And generally, January is not incredibly busy in Dover. Yes, March through June, yes. January, not as much so.
This year it's gonna
Legislature has given themselves, well, the settlement between Christiana and the state over HB 350 sets an end of January deadline. So like this year's gonna, I think, look a little different there. But I think once they're on the other side of that, we should, it's a conversation we're eager to have with them. I know we're talking to Commissioner, we should all be having that conversation.
And maybe that's a path forward.
Director Hardis, I think you had some comments you wanted to make.
Yes, thank you. So happy to add that as a measure under Goal 3 Strategy 1 to implement a reference-based pricing study. I'm happy to say a lot of that work has already actually begun. There's a lot of pending legislation in other states and also in our states that we're aware of, where we've already started to take a look at that. So I'm happy to say we've already taken efforts toward that, and I'm happy to add that. And just because I just want to make sure there's no confusion there. That's not something that we need permission from the General Assembly to do. So I just wanted to be clear on that. But yes, that work has already started. And we're
Can
happy
we
to
wordsmith
add
a little bit, just because it's not that it is benchmarked to Medicare, because like they probably, a lot of these contracts are benchmarked to Medicare. They're just benchmarked to Medicare at 300% of Medicare. So it's like, it's not not the existence of the reference, it's like the level that matters. So I'd love to wordsmith a little of that.
Correct. And there's been many studies. That the Rand Hospital study is the most recent one that I'm happy to share with the committee that looks at it by hospital type in Delaware, actually throughout the entire country, and looks at that percentage of Medicare for inpatient, outpatient, certain types of services by hospitals. We know a lot of hospitals are well over 300, 400% of Medicare for certain types of services. So we're happy to share that study that is Delaware specific, as well as includes a lot of good national data, but for GHIP specific, happy to add that again as a measure and as a report that we will work on. And we've already had wonderful conversations with our friends at the Department of Insurance as well, who are doing similar work. So happy to add that.
Karen Peterson.
Yes, thanks, Mr. Chairman. It's not something that I would just want added to this list of things that, we'd like to do, maybe we'll do someday. I would like to see us expedite a study. This is exactly what the state of Montana did when their state health plan was underwater. They went with reference-based pricing. They put it out there. They said, listen, folks, this is what we'll pay. Take it or leave it. And initially 7 of the hospital systems took it. The other one held out for a while, and then they realized they weren't getting any business from the state employees or retirees, and so they joined in as well. It has already worked in other states. I don't know why we would, put it on a list to think about someday. I think we should try to do it now and expedite it, so that as we go through, have it in hand as we go through the RFP process. That's coming up pretty quickly. Thank you.
Paul Von.
Switching to the HSA on the top bullets of this page. I'm not a big fan. In the RHB, yes, we dug into HSAs, and yes, it was something that could save the state at the expense of the participants. I'm fine with exploring consumer-driven plan options. I'm not wild about such as and having something picked out. I feel like it's a cart leading a horse, dragging a horse. And I think the consideration makes a point. I use one. I'm not covered by the state. So it's not that I have anything against HSAs, but I think from a GHIP and as far as managing healthcare costs for GHIP and members, I think there's problems with it as far as you have to have a high deductible plan, which can can negatively surprise participants in a very harmful way. And so I don't like saying, oh, this is great, this is consumer, savings. I think that's overselling and misrepresenting. So I'd rather a more generic phrasing be used in this, the first bullet on the tactic, the first bullet on considerations, rather than, and same thing as the Lieutenant Governor said, having that specific SJR 7, well, let's keep it general. I think just consumer-driven, explore other consumer-driven options, I think is an improved wording in this area. Thank you.
Lieutenant Governor.
Can I make a suggestion? How we move forward with the potential study
Sure.
based on what we have in front of us today and then in the future. Thankfully, we meet monthly. You convene us so frequently. It's fun to always be with you. I think that I agree with Senator Peterson that it's not particularly well placed in this type of document because it's a very specific action that we'd be committing to that would have a cost associated that we've been deciding on. And so potentially we could include something like the reference base in the measures, going to what Mr. Kashner was saying. And then we could put it on the agenda for an upcoming meeting as the specifics and like laying out exactly, so we could have a separate discussion and prepare for that discussion on what we want the study to do and accomplish. But that would incorporate the thought process into this today, which I think you want us to vote on today. Is that right?
I mean, it does say, it does have the leading words approval, but it, if we're not there yet.
Yeah, I can jump in here. We would love to get approval because the State Benefits Office uses this for our daily, priorities and developing our communications. We do have open enrollment coming up and we would take this and create a work plan off of it. So that's going to take us some time. And we need that in order to develop our, strategic communications for open enrollment, what our priorities are going to be for the new year. Plus our January, February agendas are looking pretty full. So if we could get a vote, it'd be great. But I think if it's a will of the committee not to, I think we can live with it.
Can I follow up on that?
Yeah, Lieutenant Governor.
This is Kyle Gay. I think if we are able then to potentially take one or two very targeted votes on adding or making, adding something related to the study, and then we could potentially vote on it as amended, we might be able to get it for our staff to be prepared for 26 would be my hope to support them in that.
Hold on back.
I would think also that we can have a non-finalized report that staff can use for their material for members and people for open enrollment and things like that. And we don't need to have the final, blessed and in concrete kind of thing if we're just wordsmithing some stuff. Is that not the case?
I suppose the staff could start working on a work plan based on this, but we need to develop a work plan with, our dates and deliverables based off of this. So let's step.
I mean, the issue of price transparency, which isn't in here, I don't think we're going to get wording that we're going to vote on today and get it in there. I don't want to skip that from the framework for 2-3 years because of that deadline when it seems like we're 98% there. It's just the last 2% we're worried about. I would hope that there's a way to be able to do what you need to do and still maybe wait until January with final approval.
Director.
Thank you, Stephanie Hartis, State Representative's Office. So perfectly fine with not taking a vote today. I do want to say again, this is more of a framework as opposed to a step-by-step guide of tasks for the SBO or the SCDC to accomplish in the next year. So I will say again, if the concern is regarding the timing of the reference-based pricing study, I don't think that specifically needs to be in the framework for us to get it done, right? We'll do it regardless if that's the will of the committee. If there's interest in being, making more specific changes to the framework, we can hold off on approval. The vast majority of the work in here that really does impact our day-to-day practices is mostly related to the high cost conditions and the programs that we're prioritizing in our promotions and communications leading up to, like she said, open enrollment, but also just our general communication structure, which is all in the quarterly communications report that you all receive. It's very similar, right? The chronic conditions that we're seeing as the leads have not been changing over the years. So absolutely to spend a little more time digging through. There seems to be a lot of really good discussions today. I think this is one of the first meetings where we've been able to really get into the meat of the topics. And I, happy if the committee wants to continue that. And maybe that looks like a specialized meeting where it's only diving into the strategic framework to get to a place where it's acceptable to move forward with the committee. And we can explore what that timing or what that would look like. But yeah, we're perfectly fine if we're not getting approval today. We'll take what we have and continue the work that we've already been doing. Because again, the vast majority of this has already been underway by the SBO.
Bill?
Yeah.
Director Hardos, Bill Oberly. It seems like we're all on board in terms of a study of reference-based pricing. I think it's important for me to understand how you contemplate that unfold. I mean, quite honestly, I'd always envisioned that would come through the General Assembly, but it sounds like you may be doing it in-house, or on your way to doing it.
Sure. So this is Stephanie again. I want to be careful because a lot of the work we've been exploring on this has actually been through an external application through the Department of Insurance, which is not led, of course, by our agency. And I don't want to speak on their behalf to the work that they are exploring, as I believe that application is not complete at this time. However, and I also want to be cautious, there is pending legislation that we are aware of in which Medicare reimbursement rates as limits in place for certain type of services. We are aware that will be coming in the next legislative session in some form or fashion. So we have been doing internal analyses on those pending bills that we have seen. If there are very specific, it sounds like this study is what this is becoming is a very robust study that the committee is looking for, as opposed to our analyses that we do for legislation that comes through, or again, with this partnership that we've been exploring with the Department of Insurance. So I would say let's hold off on getting into the details of that. I certainly would not be prepared to speak to that today. And I also, of course, would want to loop in our consultants. We've often done those studies before for other clients, as well as there's other groups out there, as Mr. Tashner had noted, who have done this work in the past. So I would ask that would be deferred to another meeting to get into the details.
Fair enough. Thank you.
Commissioner Navarro?
Just real quick, our department, members of our department are meeting with the SBO later this week to talk about our bill, which is not public yet. So that's kind of why I'm dancing around a little bit about some of the things we're talking about. And I agree with most of the things that were being said. So when Christine Vogel meets in February, she can really help with, answering questions about reference-based pricing. She can answer questions about the head model that the state is looking to pursue that will assist with hospital pricing. There's lots of things that we're working on that we're just not quite ready to discuss because we want to get it right before we put it out.
And we have any questions for the commissioner based on what he just said? Okay. So I believe where we are with regards to the strategic framework is that there are a few fine tuning, but I believe the consensus of the committee is to add in this framework some sort of conducting a study based on value-based pricing. Don't tie me down to that wording, but the sense of, I would ask the director to look at what was done in Vermont and try to understand what the scope of work was and compare it to some of the work that she's already compiled. And then based on that, she could give a kind of a summary back to this committee as to recommendations for next steps. I know there's a desire to move forward, but I think we should understand what the scope would require and what we have to date. Anybody disagree with that, Pat?
I have additional comments on
Ah,
the slide I
sorry.
haven't gotten to yet.
My fault.
They're quick though.
Yep, 1 second. Karen Peterson.
Mr. Chairman, we're heading into the RFP for the TPA. By the time Christine makes her presentation in February, we can have a study finished. All this does is possibly push it back another 3 years because we'll be doing the RFP while we're still thinking about whether or not to do a study. I think if we don't strike while the iron's hot, then we lose that opportunity for several years. And I just think we should, we could put it in this the framework to talk about the fact that we're doing it. But I don't think we should just say, we're considering it. And then after Christine talks in February, that's too late for the RFP on the TPA. So I'm just in favor of moving forward. It doesn't sound like a huge expense. And certainly it's worthwhile because we keep telling people we're doing what we can to lower prices. And we're not talking about telling the hospitals what they can charge. We're talking about telling the hospitals what we're willing to pay for our 130 some thousand people. And there's a big difference. There's a big difference legally, for one thing. So I'm just in favor of moving forward, getting proposals now and voting on them at the next meeting and moving forward. Thank you.
Slide 11, strategy 6, there's no measures. Is that something that will be introduced before we're asked to approve this?
Yeah, so
Right.
so this strategy is about using demographic data to obtain actual insights. So the measurement would just be actually doing that type of study and reporting on it.
Right, I was just saying, an annual report on that progress would be an example. And then also 2 slides later, no measures, actually on both slides 12 and 13, there's no measures for those.
Yeah, they are, because they are measurements really, right? So goal 4 is about ensuring we're measuring, it's about ensuring transparency and continuous improvement. So the tactics and the strategies that support this goal are actually measuring progress, measuring price levels, increasing transparency. So, I mean, we could have a measurement that is a list of the types of reporting and dashboards that A, already exists, and B, maybe we, envision enhancing or evolving over time.
I mean, I like the idea, just like you guys do a report on communication with covered individuals, having a report to the SBC of the progress on these strategies sound good to me. I put it out there.
This is Stephanie. Absolutely. We've been doing that and we're happy to continue that. I will say, I just want to note this strategic framework again is meant to cover the next 3 to 5 years. So I would hesitate being too prescriptive in the exact types of dashboards or things included, because that can very well change over time. But yes, absolutely. We're very happy to continue to report out on these on an annual basis.
And I think our intention, this is Kristen Short from the State Benefits Office, our intention was, this would kind of be a living document as we report out. There's no reason why the SCBC, or we couldn't make recommendations to SCBC that this tactic is not working, or some new opportunity comes up we want to add in. I don't think there's any reason on our part that, in our thinking, that we couldn't revise this as it goes along, but it just provides the benefits office a roadmap for the next 3 years, what to focus on.
And as just a general recommendation to employers, we do recommend developing some kind of strategic framework for your program, but also revisiting at least annually and refreshing, right? So just testing your progress, thinking about what new opportunities, to achieve your goals maybe, have emerged in the markets in the past year, and potentially weaving them in or weaving in the evaluation. And yeah, like taking out things that maybe you say, this isn't really, we thought this is where we wanted to focus, but we really didn't, or it doesn't make sense at this time. So yeah, absolutely want it to be a living document from year to year.
Karen, your hand is still raised. Do you have comment?
Yeah, I kept a list of things of updates to make, including add a footnote on defining how we're using the word consumeristic. Potentially making list considerations to recommend to the legislature in a future session. Thinking about using the word pricing versus spend. Striking the reference to the Senate Joint Resolution 7 on slide 9 in general. And we can think about how to add, a nice chunky bullet for this, addressing hospital costs, including potentially conducting a reference-based pricing study.
We have the list actively written down in the meeting, so
Perfect.
just because of keeping on time, we're gonna move to the next item, I'm pretty sure.
Thank you.
Thank you, we have them all written down.
Great, agenda item number 6, GHIP saving opportunities. I think Brian's gonna run through coverage of weight loss medications.
Thanks, Director Maxwell. Brian Stitzel from WTW. Following up from the November meeting, we had a few financial related follow-ups relative to the cost of providing GLP-1s for weight loss, as well as a follow-up relative to various program management programs that are out there relative to managing these utilization and expenditures relative to GLP-1s. SBO sent out information to the SEBC, background information relative to the weight management programs that are out there run through your current vendors, or more specifically Highmark, Aetna, CVS, and Teladoc, where the intent is to not go through any of those programs, but to have the SEBC review them and see if there are any specific future agenda item follow-ups that any of the committee members would like. Relative to the financial follow-ups, re-level setting ourselves. Here's a chart of expected GLP-1 expenditures. So this is the same chart from the November presentation. On the left-hand side, we had roughly $137 million in a forecast for FY26 built into our budget. To the right, we have an updated reforecast of gross expenditures. This is gross before rebates, which shows a fairly significant reduction down to about $94 million. Recall, the lion's share of that is due to, or at least the apparent effect of the formulary change from covering both Zepbound and Wegovy prior to the start of FY26 to exclusively covering Wegovy starting 7/1. You can see in July we actually saw a dip in utilization of total scripts from roughly 5,400 claimants in June of FY25, so the end of FY25, all the way down to 4,277, so a 14% reduction at the start of FY26, and haven't yet seen sort of a subsequent reuptake of people who were formerly using Zepbound in exchange for Wegovy. We've trended from a monthly standpoint at about the same run rate going forward as what we had assumed in budget. Again, this was based on data through October. We recently got November data in for an additional data point. November utilization actually saw a dip over October. So we saw another dip. We saw a 5% month over month dip in November versus October, as opposed to the expected 7% increase. We also saw a big dip on the GLP-1 anti-diabetes side of the equation. So we'll continue to keep an eye on that. But all in all, still roughly a 7-fold expected increase in overall utilization and cost from when coverage was started in FY24. A couple of the follow-ups from the November meeting were related to what would be the financial impact of increasing the member copay for GLP-1s for weight loss. At that time, we did present the expected savings of fully eliminating coverage for GLP-1s for weight loss, which is the first column on the chart on the left-hand side of the exhibit. showing total savings over the 3-year period of roughly $180 million. And that it was requested by the SCBC that we model alternatives of increasing the current copays. So the current copays for GLP-1s are $32 for a 30-day supply and $64 for a 90-day supply. So we modeled the potential savings of increasing those $32 and $64 copays to either $120 for a 30-day supply and $240 for a 90-day supply, or alternatively $200 for a 30-day supply and $400 for a 90-day supply. You can see under each of those two alternative copay structures, we have two sets of results, one labeled as a standalone copay and the second labeled as an integrated copay. What that means is that under a standalone copay, that the member would pay that, for example, $120 per prescription, regardless of where they stood relative to accumulating out-of-pocket expenses towards their out-of-pocket maximums. So even in the event that an individual had reached their otherwise combined medical pharmacy out-of-pocket limit, they would still continue to pay that $120 or $200. And then the two columns labeled integrated simply assume that the copays would count towards their accumulators, in which case if they otherwise met their out-of-pocket maximum, their cost share would go down to zero. Under the $120 copay scenarios, you can see that the total savings over the next 3 years, assuming that any of these changes went into effect at the start of FY27, is roughly $57 million for the $120 copay on a standalone basis and $37 million on an integrated basis. And were the copay to be increased to $200 would be $101 million, so close to double on a standalone basis, and roughly $47 million on an integrated basis. Off to the right, we show what the impact of any of these proposed potential changes would be on future rate actions relative to the GHIP overall. Under our most recent long-term projection, utilizing again data through October, leaving coverage intact as it is today is the first column, where we would have the 4.2% smooth rate actions continuing into FY27 and FY28, with a subsequent expected 1-year rate action in FY29 of 14.3%, all aimed at solving for a $0 deficit after reserves by the end of FY29, consistent with how we've been doing our long-term projections. Were coverage to be eliminated fully, the FY27 rate action of 4.2% could be fully mitigated down to 0%, with the same 4.2% in FY28 and a somewhat lower, about 2% lower reduced rate action in FY29 from 14.3% to 12.3%. And then all other copay scenarios, again, being either 120 or 200 on a standalone or integrated basis, all ultimately would serve to modestly reduce the FY27 rate action down to a range from 1.6% up to 3.3%, but not fully eliminate it, but still subsequently leaving the same 4.2% across the board in FY28 and the same 14.3% in FY29. So I know I went through those scenarios pretty quickly. Why don't I pause there and see if any of the committee members have questions? Representative Bomback, I think I saw you raise your hand.
Thank you. So on slide 3, bottom right figure, the 94 million projected fiscal 26. And then the next slide for fiscal 27, if we eliminate coverage, we say 51 million. Is the 94 the gross spend? And so the actual is probably, closer to like 46 or something like that. Is that the difference between the two?
So the 94 million is gross spend before rebates. The $51 million on slide 4 comparably is 1 year later. So it's FY27 versus FY26 expected. But you're correct, it is after rebates. And The results relative to eliminating coverage still assume, you can see the second bulleted footnote, we still assume that there would still be some form of ongoing utilization, either people switching over to treatment under one of the anti-diabetes drugs or continuing to use, in this case, Wegovy for other indications outside of weight loss.
And is there no assumption on this table on slide 4 of adding weight loss GLP-1s for the Medicare population?
That comes, so that's 2 slides in.
Right,
So,
yes.
so that was the second follow-up coming out of
This
the
table
November.
here assumes no change there, correct?
That's correct.
Correct.
Great.
This assumes that you only have coverage for the commercial population, as is the case today. Bill?
Bill Overly. Yeah, Bill Overly. Brian, did you consider any hybrid alternatives, increased copay, and as an example, and a requirement that they enroll in a weight loss management program?
We have not modeled that yet. It's certainly something that we could do. We would need to work in concert with whoever ultimately that weight management program was through relative to the utilization and savings expectations they would expect based on running their programs, as well as any potential implications that might have on rebates. But short answer is no, we have not modeled that type of an approach.
And I'm not contemplating that the state pay for the weight loss program. I mean, I believe there are programs out there that one can enroll in that perhaps would be validated by the state as meeting the test. I'm not trying to overcomplicate this. I'm just trying to get to a point where we don't make it financially unavailable, yet give people an alternative to not only use GLP-1s, but to live a healthier lifestyle.
And let me defer to SBO on that, but I do believe there are existing weight management programs in place today for members, but let me defer to Director Hardis on that.
Thanks, Brian. Yes, this is Stephanie. We do have multiple diabetes prevention programs that are free for the member that are in place today. We even have a pilot going on where we pay the member to be participating in that diabetes prevention program. We're about halfway through that pilot at this time. Of course, we can't mandate that anyone enroll in that program, though I will say as part of the prior authorization requirements for these drugs, the medical provider who is providing the prescription does have to attest that the individual had, I believe it's 6 months. I'm not sure if Brian Holleran is on the line that can validate that, but there is a certain amount of months that they have to show that they have engaged in nutrition changes and it changes regarding to physical activity prior to being able to access that prescription. It is part of the standard prior authorization requirements that we have in place. But unfortunately, the state cannot regulate what program that is. That's under the discretion of the medical provider to attest to that.
If I can follow.
Sure.
We could make the copay conditional on the fact that they participate in a weight loss management program, could we not?
We can. Other states have done that. Where we run into barriers there is that you are putting limitations in place outside of the standard prior authorization criteria, which does impact the percentage of rebates that we receive on those drugs. We've explored that quite a few times in the past. That's the barrier that we run into, but other states have done that where if the member chooses to enroll in that program simultaneously, they pay a lower copay. If they choose not to enroll in that program, they either A, pay a higher copay, or B, cannot have access to those medications. It's mandated. But again, I do want to note those programs, if run through the state, do have a cost to the state to administer, both on just a general administrative fee as well as a per member or per utilizing member per month basis, at least for the four programs that we have as an option through our current subscribers without going out to RFP.
Oh, I appreciate that. There's no easy answer to this. I noticed other states have jacked up the BMI levels when I read through that. Where's our BMI? Is it 35 right now? Or is
So this is Stephanie again. For the weight loss medications, we use the standard FDA approved criteria, which is a BMI of 27 or higher with one comorbid condition, or a BMI of 30 or higher with no comorbid conditions. You are correct, other states have implemented requirements of a BMI of 35 or higher. We have explored that. I will say the majority of our members who are on those medications in our plan already have a BMI of 35 or higher, so the savings was minimal when we explore that as an opportunity. But yes, other states and other employers have done that.
Thanks.
Commissioner Navarro?
Thank you. I don't know if this question is for Brian or Stephanie or maybe both, but the first question is, do we have to use our current PBM for GLP-1 drugs? In other words, could we enter into an agreement with like a, I don't know, a compounding company or something along those lines, so that, you know, we wouldn't have to go through CVS and have to worry about rebates and everything else. I'm pretty confident that the compounding companies would offer this at a significant savings, similar to what we do when we send people to centers of excellence. And then that was kind of a long question, but I don't know if Stephanie and or Brian can answer that.
So there are programs out there emerging today that leverage the direct-to-consumer market with various prior auths in place. But the short answer is no, you are not required to have it run through the PBM. It could be an excludable benefit under the pharmacy benefit program, whereby, again, you sort of circumvent the gross rebate side of the equation, leveraging what appears to be a continuing decline in the direct consumer price, be able to set what level of reimbursement you would provide to the participant. But there are ramifications of that type of a structure. One is it's outside of the plan, wouldn't count towards plan accumulators. Obviously, a couple of these copay scenarios that we're talking about wouldn't count towards the accumulators either, but could also have individual tax implications on participants.
Is that something that you've at least looked into? I mean, Willis Towers Watson has considered.
Yeah, we WTW actually has a partnership. Forgive me, I always get the two mixed up, whether it's through Virta or Vita. That
It's Virta.
Virta, thank you. That is,
But we
And
are
Save
exploring Vita.
Card, yeah.
We're
Yeah,
exploring more vendors, but it's Verta right now.
yeah, Brian,
Mhm.
maybe because I don't want to speak out of school. I don't know if you want to talk a couple of minutes about that program and how it works.
Yes, we're basically rolling out a new program, like Brian said, that would kind of merge RX Safeguard and Virta. So the prescriber would be exclusively through Virta. So a member would have to go through that limited prescribing network in order to receive a GLP-1, and then basically funnel to that direct-to-consumer pricing, whether it be with Eli Lilly or Novo for the Wegovy or Zepbound product, and take advantage of that lower direct-to-consumer pricing and forego the rebate that's already built into that pricing. And then there would be the oversight, the clinical oversight of the weight management program through Virta. But we are exploring other vendors to pair with too, including RX Safeguard. So besides just Virta, Vita, and various others that we're going to roll out throughout the year. But we did bring that up already, but we could definitely do a deeper dive if you'd like.
Yeah, forgive me if I didn't see how it was brought up in the past or learn of that, but the other questions are how many, I know we have in one of these slides somewhere, or we've spoken about before, how many people are participating within the state. And I would just like to, you know, if it costs us $5 million, I'm just throwing out an arbitrary number, to manage this, it certainly is a significant, much significant savings to what we're actually paying now. It's just a thought. If there's I didn't know if we were bound by having to use CVS, but if we're not, I think it's certainly worth exploring. Many people benefit from this.
Secretary, thank you.
Can I ask both what you're assuming on rebate trend in these projections, and then also just historically what conversations you have had with Novo or Lilly about supplemental rebates? I mean, there was just an article on the Medicaid side about the manufacturers like throwing money in Medicaid programs to try to keep coverage on the Medicaid side. So I think we given how serious our conversations are about eliminating coverage here, I think we would be in a pretty strong position to ask for some health rebates.
So relative to your question on the forecast of rebates, our forecast assume the same level of rebates that are in place today as negotiated between CVS and Novo Nordisk, basically based on the formulary change that took place on 7/1. And we assume no variability in overall rebate percentage relative to the GLP-1s for weight loss. Director Hardis, I don't know if SBO wants to take back a follow-up or talk more specifically about any direct conversations with either Lilly or Novo.
Yes, thank you. So I can say we have met with both Novo Nordisk and Lilly regarding pricing for the health plan and exploring, as directed by SJR7, the committee, direct contracting with the drug manufacturers. I can say at this time, neither Novo nor Lilly do direct contracting with employers. However, that is very likely to change in the immediate future. That information is very preliminary and unfortunately not a lot of details at this time. But yes, to your question, Secretary Link-Young, we have been having those conversations with the drug manufacturers.
And what about additional rebates?
Yes, again, very preliminary. Perhaps we can have an executive session at a future meeting to dive into that a little bit more. But yes, we've been having those discussions.
Lieutenant Governor.
I'll be quick.
Sure.
Want to make sure that we are looking at immediate costs and costs over time. And I think one of the most successful implementations, the city of Wilmington has done a good job in pairing its requirements or incentives with provision of this medication. And I want us to make sure that we look at those case studies to understand where we don't have data, what similar populations that do have data can tell us about what we might save in ER visits or hospital visits or insulin costs and things like that. And so that we are right sizing our approach to cost savings in the immediate term versus what we might realize in the long term if we make, for lack of a better term, an investment. So I'm seeing it both ways, and I want us to tackle costs holistically.
Bill Oberly. And I think that's really where I was headed with a hybrid model where you teach a healthy lifestyle, eating habits, exercise, rather than sit home and just inject yourself twice a month. I mean, if you don't look at it holistically and change someone's lifestyle, the outcomes are not going to be as good if you can get them into the right frame of mind and diet and exercise. Lieutenant Governor.
And I appreciate that. I just want us not to use, I don't want us to rely on stereotypes about health, weight, or these drugs. I want us to understand how these drugs are chemically and in practice affecting the population that we're serving. And I want us also to recognize that many times these drugs are used for individuals who cannot be as active. And so it's less about learning as it is empowering them to find alternate ways to their health journey, and that teaching people, 60 years into their health journey, something new can be difficult. And so I want to make sure that we are educating ourselves around this table about these drugs and about how it's going to change healthcare.
And I would just echo what the Lieutenant Governor said. I mean, clinically, what these drugs are doing is taking people who have a different biochemistry and giving them the biochemistry they need to be successful. It is not a substitute for willpower or frame of mind or commitment to exercise or anything like that. It is giving people the biochemistry to make them successful and fundamentally enabling people who, prior to the existence of these drugs, had very little chance of having the kind of life in their later years that the rest of us look forward to with our grandchildren. And these drugs are doing something biochemically that is incredibly important. And it is not a matter of lifestyle or willpower like that.
I appreciate that. That's why we have a dialogue. So.
Great. I think, can we go to just slide 6, Brian? And I think Paul Bombach wanted to kind of understand the cost with providing GLP-1 weight loss coverage for the Medicare population.
Sure. So the numbers on this slide present a forecast of the added cost to the GHIP of covering GLP-1s for weight loss for the Medicare population consistent with the commercial population, meaning under the plan with the same $32 and $64 copays. Key driver of this analysis is that the Medicare population tends to utilize GLP-1s for weight loss at a fraction of the rate that the non-Medicare population does for a number of reasons: stages of life, reactions to medication, not as focused on managing weight, et cetera, et cetera. We've assumed that the utilization rate for the Medicare population would be 25% of that, of the commercial population, which all other data indicates is sort of at the top end of the range. We've seen utilization ranges from, as low as 10% up to 25%. So this conservatively assumes the 25%, which would add a total cost over the next 3 fiscal years of about $23 million, assuming that none of this cost is covered by Medicare directly, and that the impact of that $23 million to the right, what that would do to those same 3, 4.2, 4.2, and 14.3% otherwise GHIP aggregate rate actions, increasing FY28 to 4.4% and FY29 to 15.8%.
And what level of the cost for Medicare, given the developments that have been announced as well, but not like signed, sealed, and delivered, what's assumed regarding the GLP-1 prices for the Medicare population of these projections?
So nothing is assumed relative to any of the developments out of the capital. So it assumes the same level of cost, both gross cost rebates, member cost sharing, as is in place today under the commercial plan.
That's great. I appreciate it. Thanks, Brian.
Sure.
This is Paul Bombach, I should say.
So seeing no other questions, I can turn control back over.
I would just put a plug in for the work that Kristen did on her document here of updated as of December 10th, but it kind of gives the landscape of what's been happening in other states as far as coverage with regards to GLP-1s for weight loss, not only for employee health plans, but also for Medicaid programs. I would encourage everybody to read that. Next, we have agenda item number 7, pharmacy benefit management request for proposal.
Is there going to be a vote on this issue?
Which one?
The PRC for the PBM?
No.
Thank you.
No vote.
As there were 2 members leaving, I was concerned. Thank you.
One went to the back.
Oh, there we go.
Thanks, everyone. This is Stephanie Hardis again with the Statewide Benefits Office. So I know we do actually have quite a few committee members who have a hard stop at 4, so I'll try to move through this relatively quickly. We're continuing the conversations on the PBM RFP for pharmacy benefit management services for the commercial contract effective July 1st, 2027, and the employer group waiver plan Medicare Part D population effective January 1st of 2028. So as follow-ups from the October SEDC meeting, we had briefly reviewed the upcoming procurement and proposed changes to the PBM RFP in contrast with the RFP that was previously approved and subsequently canceled. So I had requested committee member feedback on these proposed changes, specifically focusing on the minimum requirements and the criteria weight. No changes were proposed or received from committee members for the questionnaire portion of the RFP. Discussions also took place, of course, on the proposal evaluation process. So I really want to encourage us today to focus on the minimum requirements and criteria weight, just so that way we can get over a full RFP draft to the committee in January to ensure that we have at least 2 months to work through that. And I also just want to note on that item of the PRC and evaluation process the revised language that's in the RFP, which is provided by GSS, is broad enough to cover either scenario, whether it's a PRC or a subject matter led evaluation process through the SBO. So again, those conversations can continue, will not dictate or change the language of the procurement, but we want to get this draft out in January. Next slide, please. All right, so minor proposed modifications.
Chairman Peterson?
Thank you, Mr. Chairman. Back to the last slide. Oh, I should say, in item number, or requirement number 16, we're scratching the language that talks about cost plus pricing. Is that something we decided to do, or because that was real important when we were putting the RFP together? Why did that come out? Is it that nobody agreed to do it, or what happened?
So thank you. This is Stephanie again. I want to be very clear. We cannot speak to proposals received under the previous procurement that has been canceled. That is a requirement of procurement law, but I can say, and again, we're going to go through all of the minimum requirements, but if we're jumping to that one specifically, number 16, not every PBM offers a cost plus pricing proposal. However, there are other alternative pricing proposals that exist. So for number 16 specifically, this minimum requirement opens the language to allow for other forms of alternative pricing proposals, not just cost plus models, but does allow for those to be submitted. And it also confirms that PBMs will not be disqualified for failing to submit an alternative pricing proposal, because again, not every PBM offers that. And the intention of the committee, to my understanding, which is still the case, was to open this RFP up to allow for as many bids from PBMs as possible. So we don't want to restrict to only those that offer a cost plus model.
Well, the reason I raised the issue, and it does relate back to the one you were just talking about, which is why it rang a bell. In the last RFP, not the one we canceled, but the one that we're working under now, we had similar language, and it said that they had to provide cost plus pricing proposal, otherwise they would be disqualified. Nobody proposed anything, and nobody was disqualified. So I'm not sure that this is meaningful at all, because we are trying to get to a cost plus pricing proposal, but if we don't require it somehow, then we're not going to get it, as evidenced by the last RFP that we're under right now. So is there language elsewhere in here, Stephanie, in the proposal that would cover this?
So Ms. Kingston, to confirm, in the 2020 RFP, the language you are referencing stated, I apologize if this is not word for word, this is from memory, but it stated, confirm your organization will supply a cost plus pricing proposal, which all vendors who were finalists did submit yes that they would. However, the SEBC at that time was not interested in reviewing those proposals, so they were not submitted for consideration. There was no language specifically that said you will be disqualified if you do not submit a cost plus proposal. So I wanted to make that clear. If the intent of the committee is to only entertain proposals from vendors who do have cost plus models, we can certainly revert to the prior language. But I believe that contradicts a bit of what the committee was looking for, which was to explore other models outside of the current transparent design that may or may not fit the definition of a cost plus pricing proposal. As I stated, there are many, especially newer PBMs out there that do offer alternative proposals outside of transparent pricing, outside of the traditional, and outside of cost plus that the committee would be interested in exploring.
Okay, I was just worried that this is coming off the table, but what you're saying is that it's still on the table, but other options are on the table with it. Is that?
Yes.
Am I understanding what you're saying? Okay.
Yes, and as you're looking at the materials on the screen, anything that's in yellow is an addition or a technical revision. So for that specific minimum requirement, it does state that the state is interested in evaluating alternative pricing proposals, including acquisition costs or cost plus pricing proposals. And then there's just more information of how that would be defined as far as elimination of spread pricing, reimbursements for pharmacy and prescription claims, which again falls under that original definition of the cost plus pricing proposal. But yes, this still allows for the solicitation of cost plus pricing proposals, but also allows for alternative proposals that do not fit that exact definition.
Okay, thank you, Stephanie.
First page of your minimum.
Yeah, we can actually skip the first one. You can just go back one slide, please. All right, so sorry, 2 ahead. Forward. Okay. Yes, perfect, thank you. So as I stated, anything that's highlighted is either a technical revision, so changing of a date, or changing the attachment number, or it's an addition to the minimum requirements in comparison with the recently approved and discontinued RFP. Minimum requirement 10, very technical in nature. It's really just asking for the PBM's registration number. Numbers 11 and 13, so this is regarding experience of the PBM. This language serves to clarify that the requirement for managing PBM services for 3 years and for 3 clients with similar scopes is for each line of business, meaning if a vendor is submitting proposals for both commercial and AGWIP, they need to demonstrate that adequate experience for both client types. This was implied in previous discussions with the committee and in the prior RFP, but we recommend that it be clearly stated. So that's where those revisions come in for 11 and 13. Number 14, that's more of a technical revision that allows the position of account executive and account manager to still be accepted if the PBM has a different title for that role, so long as the functions are comparable. It allows the PBM to describe the exact responsibilities of the person who would be supporting that work if their title is different under the vendor that they work for. Number 5, so this one is pertaining to rebates. This proposed revision allows organizations to provide a definition of a rebate if it is different than that proposed of the state. This does not guarantee that we would accept that definition, but it allows for more opportunity for negotiations as opposed to immediate disqualification.
You said number 5, number 15.
Number 15, sorry. As opposed to an immediate disqualification for not agreeing with the exact verbiage of the state. Again, more allows for that negotiation process. And there's also language added that allows for PBMs who are proposing a model that is not based on rebates to provide a response on how they would handle the type of payments that are described in that definition. So, for example, there are models out there that operate on a PM basis as opposed to utilizing rebates, which we're seeing more of in the market, and just wanted to allow that opportunity for vendors who are proposing that type of model to describe how they handle the other types of payments that would typically fall under a standard rebate. Right, next slide, please. Great, so we already went over number 16. Number 18, so the modification here removes the language regarding the auditor being solely of the state's choosing. Now I know that language was recently added by the committee in the latest procurement. In previous contracts, both with PBM as well as just with other vendors in the statewide benefits office, it is often mutually agreed upon between the vendor and the state. And we believe it would be beneficial to continue that practice in this procurement.
As Paul Ballmer, can we have that language about mutually agreeable? Because that's missing from the draft you have here.
Absolutely.
Thanks.
All right, moving on to minimum requirement number 22. If you could go to the next slide.
20.
Yep.
I was unclear. Changes will not be allowed unless there is a 10% or greater loss to total rebates.
Mm-hmm.
That seems odd. That we'll only make changes if we get screwed over.
No, it's a positive thing for
Okay,
fixing.
good.
So what it's saying, and this is in our current contract with CVS, it's pretty standard language across the board. So what it's saying is that the vendor cannot make changes to their minimum rebate guarantee unless they experience a 10% loss in rebates. So say, for example, our minimum rebate guarantee is $80 million for fiscal year 28. Even if we only receive $75 million in rebates, now the PBM owes the state $5 million. So this is saying we will not renegotiate those minimum rebate guarantees unless there is a loss of 10% or greater.
A loss to the organization, not to the state.
That is correct. We receive 100% pass-through of all rebates.
So can we have a loss in total rebates to your organization? Make it clear who is suffering that loss?
Yeah, absolutely.
Okay.
pull from the contract.
Pure
We're happy to
clarification.
work with that. And that 10% again is standard. You might have some PBMs that only want to do 5% or may push back on that entirely.
Yep.
So if the committee wishes to change the 10%, they're more than welcome to do so, but I would say that's pretty standard across the industry at this point.
Thank you. This again was Paul.
Great, so going on to the next slide here. The final two modifications, number 22 here, again, the definition of rebates, just clarifies that it would be as agreed upon with the state, in the instance that it's not the exact definition included in minimum requirement 15. And number 25, this is just a clarification that the insurance amounts outlined in the RFP are non-negotiable. These insurance amounts are not determined by the statewide benefits office or the SEBC. They are determined by DTI, our technology department within the state, and they are non-negotiable. There's been, not just within this RFP, but in many other RFPs, attempted pushbacks on changes, especially for our cyber liability coverage, which is a rather new requirement. And we just want to make it very clear for the vendors that cannot be negotiated.
All about that.
Two things. First on the last one, shouldn't the word minimum be in there? Minimum insurance amounts outlined in the RFP.
Sure, the insurance amounts in the RFP are very clear based on the number of claims, so it's a tiered approach. The insurance amounts will vary based on the amount of claims received. So it's not.
Okay.
If there's,
Okay, so
I can look into adding, it works.
If you ask the question, whatever answer you get is fine with me.
Okay.
Okay. And then the other thing is, 15 does not say that the rebate agreement is usually agreed upon or is agreed upon. It's just presented in 15. So I would say, yeah, there's no as agreed upon language in 15. So language in number 22's wording doesn't work. As presented would be accurate. I'm not sure that's what's wanted. But there's no agreement in 15.
So the proposed modification that we received from a committee member was to modify that. This was on slide 2. I think we initially kind of jumped right past it to get into some of those questions, but to confirm if your organization will pass through 100% of the rebates, and then it states what the state's rebate definition is. And then we state if your organization uses a different definition of the term rebate, please provide that definition for the state's review and consideration.
Okay, it's okay, but not approval.
Correct. We're not
22
guaranteeing
says 22 says approval as agreed upon.
with the vendor who is selected from the SEC.
It's after the fact.
Yeah, correct. That would be in the contract. We don't want to lock ourselves into agreeing to a rebate definition that the committee may not agree to.
Then can you add a sentence that maybe to 15 that says the successful that issue of there will be a step where the state and the organization will agree upon a definition. It may only be with the successful vendor or whatever, but there is.
There is
when you
review
say
and
it's not in there,
consideration. It says review and consideration.
right, but there's no.
You want them to actually have it
There's
agreed.
no agreed upon. Now, I understand you're saying applicants don't need to have it agreed upon. I get that.
Correct.
But 22 talks about that you're gonna do this reporting in accordance with the definition as agreed upon between the state and the successful.
Yes, and
Okay,
the
maybe
successful
that's
vendor.
the wording would be as agreed upon with the state and the successful applicant or successful
Yeah,
vendor.
to be
something like
awarded
that.
vendor.
Yep, is that all right? Thank you.
So the update would be to 22, not to 15.
Yes. Yeah.
Right, there's no other questions on the minimum requirements. I do just want to touch through the scoring criteria, please. There was a proposed modification here, so and again, anything highlighted is an insert. So for the financial terms, number 40, for financial terms for 40 points, alignment with the state's definition of rebates is included now in that scoring criteria. And if you go to the next slide, we also added under audit rights, transparency, net cost, and flexibility. A portion of that scoring will be tied to flexibility. for implementation of desired contractual components. So those are items that are not included in the minimum requirements, but are in the questionnaire, which is specifically direct contracting availability, flexibility to enter into interstate compacts for drug purchasing, items that we have discussed under the resolution and incorporated in the questionnaire.
Just, sure, go over it. From my better understanding, identification, that would allow for, I use the term carve out during the life of the contract at your discretion.
For
What's
for
the-
direct contracting for certain drugs, yes, it would.
Okay, all right, thank you.
I don't know if this is needed on slide 7, the alignment. I would think it's degree of alignment. Alignment sounds like it's a yes or no. Is that, we don't need to worry about that level of detail, is that correct? In your view?
If we want it more on a sliding scale, absolutely, it can be degree of alignment.
Because I'm imagining, given our experience with the last RFP, that it's not gonna be yes or no. But I don't know if we need to have degree in here to make it clear with scoring criteria.
So on second thought, since this is 40% of the weight of the scoring, I actually would prefer it be rather rough, yes or no, right? You would want the vendor to agree on your definition of rebates. With this being such a high score, a high portion of the criteria,
But let's say we've got 5 applicants, none of which accept our thing,
they would,
but they have definitions that are on a spectrum. I would like there to be the ability for the PRC to say, these guys are closely aligned, these guys are not anywhere close to aligned, and be able to have that in their scoring without violating the criteria.
yeah, absolutely, that would be part of this scoring. There's a difference between the meeting of the minimum requirements and moving on to a finalist where you're then scored. With the prior RFP, it never got to that point where there was scoring.
Can I add to this, Stephanie?
Sure.
Then during the scoring process, we actually talk you through giving them a 1, 2, 3, 4, or 5.
Yeah.
And I think that degree would come in there versus in the scoring criteria
So
definition.
the degree is inherent is what you're.
Yes.
That's, I'm fine, Good, thank you. And truly, that's the last comment. So,
Well, you might have to. I did just want to note on the next slide, so we did get committee member feedback on these 2 topics, so audit rights, transparency, and flexibility, and also the ability and capacity to provide requested services. There was a request to switch the criteria weight for those, so giving a criteria weight of 20 for audit rights, transparency, and flexibility, and decreasing the criteria weight for ability and capacity to provide requested services from 15 to 20. So the SCDC, if there's interest in that, I will say in general, the ability to administer these services cannot be understated. It's very important to this contract, especially something of in AGWIP, which has such vigorous reporting requirements. We really want to have someone that has that experience and ability to administer those type of plans. But again, that was feedback that was provided by a committee member if there's interest in modifying those criteria weights.
Didn't you say you did?
I made prepared comments, I'm responding, hold on back. So I appreciate it. In past PRCs, did you find that, this, sorry, I missed the page, this level of ability to do that, varied a lot? My sense is there were, the thought these 3 or 4 all hit that. So, it being 40 or 20 or 15 didn't really matter because all the ones that are the finalists of the finalists all hit it. And therefore, I think it's good to have a higher weight in something that has a bigger variation and a lower weight in something that's either there or not.
Great.
Thoughts?
Great question. So where this varies now is that the SCBC has significantly decreased the experience requirements of a PBM to enter into this RFP. So previously in 2020, in order to even be considered for an AGWIP, you had to have 10 years experience. That's now 3, based on what the committee had wanted to change for this procurement. Same for the commercial, I believe it was at least over 5 years, and again, now it's 3 years experience. So to your point previously, when a vendor would make it through as a finalist, they've already proven that they have that level of experience. Whereas now with the requirements only being 3 years of experience, a higher weight could be beneficial, right? So let's just think about the AGWIP, for example. So we get $100 million a year in revenues for administering an AGWIP, but there's very specific requirements that a vendor needs to meet in order to maintain that. And if they're not able to meet those requirements, the state is not able to administer an AGWIP, which means those $100+ million a year in subsidies we receive would go away. We wouldn't be able to administer that program. So having a heavy weight on the vendor's ability and experience is really important in that aspect, since we've already reduced from the minimum requirement portion that 10 years experience down to 3. This is a way for those more experienced vendors to score a little bit higher as they have more proven experience to administer in that capacity.
You may not be able to answer this. Of the applicants of the previous cycle that did not move forward, do you happen to recall there being a wide range in that background and ability where you could see this category having a lot of space? Again, if it's an area where there's a wide range, then I'd like to see a high weight. But if it's an area where we're seeing a pretty narrow range, I don't want to waste points on the weight to that. Does that make sense?
Exactly. So I can't speak, of course, to the exact proposals. I can say from a market standpoint, there are a lot of newer PBMs who have emerged over the last few years, who maybe do not have that level of experience as the more established PBMs, who likely would have interest in bidding on this procurement.
Thank you.
Karen Peterson.
Thank you, Mr. Chairman. Stephanie, the number 20, the bullet point number 2, ability to duplicate existing plan designs and match existing clinical programs. If somebody were to come in with a cost plus plan, are they going to be penalized under that because they're not duplicating the existing plan?
No, because under that minimum requirement, they are also required to submit a transparent pricing proposal which matches the current plans.
Can you say that again slowly?
Sure. So as part of the minimum requirements, so number 16, yes, does allow for those alternative pricing proposals. But if you go down one more to minimum requirement 17, it requires the submission of a transparent cost pricing proposal. That is the type of proposal. You know, obviously, the word transparent can be defined loosely and defined differently by certain individuals, but that is the type of pricing model that we currently have in place. So we are asking for multiple proposals, one that replicates at least as closely as possible. And when we say replicates, what we really want and mean is, you know, we don't want a PBM with such a narrow network to where our members can't go to Walgreens to get their prescriptions, right? Because they're not in network. And that certainly could exist if we didn't have those type of provisions in place as far as replication goes. So to your point, Ms. Peterson, no, that wouldn't act in a way to harm those additional pricing proposals, because it would be in addition to the transparent proposal as opposed to separate, if that makes sense. And again, that would be more delineated in the scorecard. These again set the scoring criteria. However, in the scorecard, there's more kind of robust breakdowns for how to actually score the individual proposals, in which there would be 2 separate scorecards for an alternative pricing proposal versus a transparent pricing proposal.
Okay. All right. Thank you.
Really? Any additional questions related to the scoring criteria? Great. Well, I have everything that I need to get the full draft of the RFP out to the committee ahead of the next SEBC meeting. There are, of course, an additional topic that I know the committee is eager to discuss related to the evaluation process. Chair Maxwell, if you are interested in having that discussion, we can do so. I know it's 20 minutes at the end of the meeting.
I actually have to get.
Okay.
I'm not trying to dodge the conversation. I just don't have time to have it today. So we'll put that on the agenda for next meeting.
So that'll be,
Bill.
that'll be the discussion around PRC.
Yes.
Thank you.
Public comment?
We have, Stephen LePage, who's signed the. I was sharing. Stephen LePage.
Thank you. I'm glad we're talking about Medicare reference-based pricing. The director mentioned problems with North Carolina, and that's true. I've done a lot of research in the area, and I spent about a month and a half just doing this research alone. And part of the problems for North Carolina was they weren't battle ready. So when you talk about out of network, that's true. They said, well, we'll just go out of network. But part of planning for that is to say and have it stipulated that your out of network is 185% of Medicare reference-based pricing. If your in network is 200% Medicare reference-based pricing, they're gonna want to stay in. Right? So the other part of that is you talked about TPAs. So you want to have them have rack networks. So your people can go somewhere else. So you want to prepare for this battle because it's going to be a battle. And you want to do stuff with balanced billing because you don't want your members harmed with balanced billing when they have out of network costs. So I spent the time for about a month and a half, and I have all this documentation here that I went through painstakingly. It's got legislative clauses in here. It's got clauses for TPA contracts. It's got a whole slew of things of where it goes, whether it's belongs in the legislative, statute, or whether it belongs in the TPA contract, or both. So this one here is Delaware GHIP Medicare reference-based pricing. There's 40 clauses in here. This one is dual vendor supplement clauses. So you can have a vendor do the heavy lifting for the SEBC. Okay, the SEBC never goes in contact.
But your time is up. If you want us to distribute something, you can send it to SEBC email.
It's a pretty deep subject.
So we also have somebody online. If you could state your name. Tell them the last 4 digits so they know it's them. 6756.
Hi, this is Elisa Diller, and I would just like to say that the sooner you move ahead with some kind of study, I think the sooner you will start saving money. So I'm just echoing Senator Peterson's comments. Thank you.
Thank you. Is there anybody else for public comment?
We have other business. Anybody have anything to discuss under other business? Oh, Karen Peterson.
She's unmuted. It's
I'm sorry. I'm on now. Okay. A couple of months ago, we talked about looking into reverse auctions. And my understanding was the administration was going to start to look at that and, explore that and research it and so forth. Have we made any progress on that?
Legislation has been passed to allow for reverse auctions, yes.
Okay, so we're working on it?
The current RFP that's being developed by the SEBC is not for a reverse auction.
No, but I realize that, but we said we would start looking at that, not for this one, but for future contracts. Has anything been done on that?
I apologize. I'm not really tracking the exact request. Again, the barrier that was in place earlier this year was related to legislative and procurement law, which has been now passed and rectified to allow for reverse auction for PBM services under the GHIP. Unless there is interest from the committee to alter the upcoming PBM procurement to style it as a reverse auction, likely require an additional extension if we were to look into that. No, there is not immediate work being done on that. We don't have the staffing and capacity to currently develop two simultaneous PBM procurements.
Yeah, I thought we were going to be looking into how we would do it in the future. That was my understanding.
And we still
maybe
Absolutely.
Yeah.
Plenty of time. That would be in 2030 if none of the optional one-year renewals are utilized under the upcoming PBM procurement.
Okay, and that's what we had agreed to, that it would be, we'd be ready not necessarily ready, but we would know how to go forward with a reverse auction if we opt to do that. So thank you.
Yeah. Absolutely.
Any other business? Paul Baumett. Motion to adjourn. Second, anyone?
Second,
All those in favor say aye.
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 Opposed? Nobody's opposed? All right, thank you so much. Be careful getting home.
When did you?
So we're like mid-October. Sure, right? It's too many.